Hello, my name is Ross Johnson, and I am a third-year medical student at Creighton University School of Medicine. Amyloidoses are a rare group of disorders caused by extracellular deposition of abnormally folded proteins in various organ systems, leading to progressive organ damage. Clinically, gastrointestinal amyloidosis can present as nonspecific symptoms including gastric outflow obstruction, hematochezia and hematemesis, obstipation, perforation, epigastric pain, nausea, vomiting, and diarrhea. In the GI tract, vasculature, nerves, and nerve plexuses are damaged by amyloid deposition within the muscularis mucosa, leading to blood vessel frailty, decreased gut wall compliance, and decreased peristalsis. Once amyloidosis is confirmed on biopsy, further workup should be performed to rule out other organ involvement, most notably cardiac and renal. Here we present a case of GI and renal amyloidosis in a 48-year-old male. A 48-year-old homeless male smoker with history of type 2 diabetes mellitus, congestive heart failure, polysubstance abuse, MRSA, and DVT presented to the emergency department unable to ambulate secondary to chronic bilateral lower extremity wounds. Patient had normal vitals and an unremarkable physical exam aside from extremity wounds. The patient complained of diarrhea and has had unintentional weight loss of 83 pounds over 1 year, but denied hematochezia, hematemesis, or melena. In a prior admission, patient was diagnosed with renal failure with nephrotic range proteinuria. He was then admitted with a hemoglobin of 5.5, an MCV of 89.4, and an elevated BUN and creatinine. During his stay, the patient was transfused 5 units of packed red blood cells and was worked up for chronic anemia. EGD showed amorphous eosinophilic material with apple green birefringence on Congo red stain consistent with amyloidosis in the gastric antrum, gastric body, and duodenum. Kidney biopsy for chronic kidney disease showed expanded glomerulus with amorphous eosinophilic material which was Congo red positive, weakly PAS positive, and Jones negative. You can see that in Figure 1 and Figure 2 showing the separate duodenal biopsies as well as the renal biopsies, and you can see the positive birefringence in both. The amorphous material was found to involve arterioles, arteries, and focal areas of interstitium staining for IgA, kappa, and lambda light chains. Prior to treatment initiation, the patient left against medical advice and was lost to follow-up. Our case provided a rare presentation of amyloidosis involvement of the gastrointestinal tract. While involvement of the kidneys is rather common, GI involvement can be as low as 3.2%, as found in a retrospective review of patients with amyloidosis in a tertiary referral center. Overall, this case adds to the literature by demonstrating how gastrointestinal amyloidosis, a rare iteration of amyloidosis, may manifest with findings of diarrhea, weight loss, and anemia. The prevalence of AL amyloidosis is believed to be around 2,200 annual cases in the United States. Genetic variations within amyloid-producing genes combined with autoimmune and infectious disease create chronic inflammatory states, leading to widespread deposition of amyloid. This occurs in the muscularis mucosa of the gastrointestinal tract in close contact with vasculature and nerves. Deposition causes frailty of the vasculature, thus hindering peristalsis and compliance of the tract. Our patient presented with severe anemia, prompting the care team to look for sources of bleeding, which led to the discovery of his amyloidosis. It is our hope that underserved patients with complicated medical histories will be worked up for this pathology in the future.